Everybody, and thank you very much for joining us. I hope you've had a good day wherever you are. My name is Jerard. Some of you may have heard me speak before, and as those who've heard me speak before will know, I was a consultant surgeon before joining the MDU about 10, maybe coming on for 11 years ago. And I've got two people joining me tonight, and I'd like to introduce to you Dr. Quinn, who's a consultant in renal medicine in Belfast, and he's got a particular interest, among other things, in medical consent. Joining me also is Dr. John Dale Skinner, who was working as a GP in London until very recently, at the same time as being, like me, a medico-legal advisor for the MDU. Now, if that wasn't enough work to have on his plate, John also worked with medical claims. So he was a senior medical claims handler here at the MDU. So he might see issues of consent coming into play in claims in medical negligence. I'm going to talk to you very briefly about guidance, but only briefly, you'll be glad to hear. And then Mick is going to give us his perspective and experience on the front line. John is going to be in the background marshalling your questions for us, and then he's going to put them to us and discuss them. And we're going to discuss them as a group and try our best to answer them. Just to put it into context, we usually have about 700 or 800 people at these talks, and it means that the volume of questions can be enormous. We'll do our best to try and address questions that are clearly put and easy to understand for us. Sometimes the questions are so complicated that we really can't answer them, but we will do our best. So put your questions in the question box of GoToWebinar, and afterwards, once this is all done, once you've given us some feedback, you'll get a certificate of attendance. And just in case anybody misses part of the talk or the whole webinar, the webinar will be on our website for you to access along with our e-learning modules and our other courses. There's one e-learning module on consent, which is just in the process of being policy ready at the moment and being checked. It will be available along with all our other e-learning courses on the website, so do have a look at that. It's easy CPD for you to get and to add to your record of CPD. If there's anything else that you want us to talk about, topics you think we should be covering in these meetings, and if any of you have a burning desire to share your experience in a particular area of practice, then do let us know, again, through the feedback form. So consent, as you know, is a topic that has exercised the British courts and the medical profession for some time. I mean, it's a recurrent issue for our members. I'm sorry about this slide. Caroline doesn't like it. Caroline's sitting in the background. She's in charge of the marketing side of things and helps me coordinate these things. And this slide comes from our own internal records, and it shows that we still have a significant number of files coming through every year which involve consent in one way or another. They're often not just a clean consent issue, they're often a complaint associated with an outcome of a procedure, and consent is added on as an issue, as in you didn't tell me about that. Or it's a doctor doing an examination of a patient, and the patient not being happy with the consent process before that assessment is done. So this graphic displays our cases over the last 10 years where consent has been an issue for members. We still get regular calls about consent from hospital doctors. Out of hours, it's quite common as well, doctors worrying about whether they can or should be treating a patient who's turned up. So this evening, Mick's going to outline his thoughts on this topic for you. And just to set the scene, I'm going to share some very basic information and talk through legal developments. So prior to 1985, what a doctor told the patient was basically based on a thing called the Bolam principle. So if a body of doctors felt that the information to be given to a patient was X, and the doctor did that, then that was fine. Okay, that's the general approach. In Scotland, it was much the same. It was Hunter and Hanley, but the same principle would have applied. In 1985, this principle was put to the test in a case called Sidaway. The patient had a chronic pain had a neurosurgical procedure to try and relieve that pain, and she was warned about the risk of nerve root damage and spinal cord injury. Needless to say, she was one of the unlucky small percentage of patients who had a spinal cord injury and a significant disability as a result. She argued, unsuccessfully unfortunately, that the neurosurgeon had failed in his duty to warn her of this significant complication. And the court held that the amount of information that needed to be disclosed to a patient was a matter of for the exercise of professional skill and judgment, just like the Boland principle said. So, if a reasonable body of medical opinion thought that sufficient information had been disclosed, then that's okay. The court said the only effect that the mention of risks can have on a patient's mind, if it has any at all, can be in the direction of deterring the patient from undergoing the treatment which, in the expert opinion of the doctor, it is in the patient's best interests to undergo. In other words, you don't want to be deterring the patient from having the treatment that the doctor's decided is right for them by telling them about a nasty complication. Not an approach that I would envisage is many doctors taking in this day and age in this country. The first ethical guidance wasn't published on this issue till 2008, and 20 years later, the approach to medicine and to consent had changed significantly. Interestingly, the guidance from the GMC at that time didn't even mention Sidaway in its legal annex. It referred to a case called Chester versus Afshar, but it started talking about the change in approach, that medical paternalism didn't apply in the same way, that doctors had to start taking into account what patients wanted to know about. Montgomery was a really fundamental case in this regard. It came out in 2015. I'm not going to rehearse it. If you want to understand the implications of Montgomery in detail, we've got information on the website. We've got a previous video about it. But basically, it introduced the idea of material risks. Montgomery requires clinicians to tell patients about material risks involved in the recommended treatment or any reasonable variant of treatment. The test of materiality being, in the circumstance of the particular case, a reasonable person in the patient's position would be likely to attach significance. So in the circumstances that we now work in, you're expected to check with the patient what they would be interested in hearing about, what concerns they have, and you would be expected to disclose material risks to them. In 2020, the GMC updated their guidance on consent to reflect the changes in case law. So what we were having over time was we started off in a particular position, which was the Boland requirements, then Sidaway came in, then the GMC guidance went above and beyond what the courts recommended. The 2015 Montgomery judgment really just brought the courts up to the same place the GMC had already been for about 7 years. In 2020, we got new GMC guidance, and it set out 7 principles of consent or decision making, which clinicians needed to apply to the particular clinical context in which they were working. I'm not going to try and go through all 7 of them, but just very quickly. They said all patients had the right to be involved in decisions about their treatment, their care, and to be supported to make informed decisions. Decision-making is an ongoing process focused on a meaningful dialogue, on the exchange of relevant information specific to the individual patient. All patients have a right to be listened to and to be given the information that they need to make a decision and the time and support they need to understand it. Doctors must try to find out what matters to patients so they can share relevant information about the benefits, harms of proposed options and reasonable alternative, including, really importantly, the option to take no action at all. There have been some post-Montgomery cases which are relevant. In fact, there have been a whole slew of post-Montgomery cases, all of them, a number of them focused on quite small areas. The ones that have stood out, I think, are probably Deuce versus Worcestershire Acute Hospitals NHS Trust in 2018, in which the reasoning was really consistent with Montgomery. So this was a gynecological operation for pain, and the patient was not warned about the risk of chronic pain resulting from the procedure. The patient complained and lost at first instance in the first case, but it went to the Court of Appeal, and they decided that that a doctor only had to warn somebody about things about which they could reasonably be expected to know. So the doctors weren't really aware of chronic pain arising from those procedures back in 2008. The state of knowledge later was different. But doctors couldn't be expected to tell somebody about something they just didn't know, or the state of knowledge was not there. There was another case in 2023 called McCulloch, which some of you may have heard of. This is the court facing a dispute as to whether a particular treatment is a reasonable alternative. So you've got a patient who's got a condition, you know about it, what are the alternatives open to them? Well, I guess that it's a matter of professional skill or judgment, and as to what those options might be. But the people who were appealing the judgment said, no, it's not about what the professional thinks. It's a matter of what's relevant to the patient and to the individual. The court actually stood with doctors in that one. The court unanimously held that whether a treatment is a reasonable alternative is to be determined by the application of the professional practice test, so what the doctor thinks. A doctor cannot, however, simply inform a patient about treatment options or the options that he or she and him or herself prefers. Instead, once a range of reasonable treatments have been identified, absent any indications to the contrary, the doctor must explain all of those alternatives and the risks involved to the patient. However, the doctor is not obliged to tell a patient about treatments which a doctor doesn't think apply to this patient or to that patient. And that is where the application of professional judgment comes in. In terms of the practicalities of it, we often get asked, how should I be recording this consent process? I know that Mick's going to talk about this in his presentation. And the short answer is there is no one-size-fits-all approach to this, but we always talk about ensuring that the patient's symptoms and their severity are recorded, what their specific concerns are, what they're looking for from the outcome, things they would want to avoid, their questions about the procedure, and some sort of record of the discussion of risks, benefits, and alternatives, including the option of conservative management of their condition in the current context. Right, after that rapid canter through a lot of complicated case law, I'm going to hand over to Dr. Quinn. Mick, are you there?
Yes, hello. Hopefully you can hear me.
I can hear you perfectly. I'm going to go quiet and disappear and let you carry on. And just you tell me when you want me to move the slides on.
Perfect. Thanks very much, Jerard. Good evening, everybody, and thanks for coming along. And hopefully we can have an interesting discussion about the principles of patient consent and decision making. And I think it's important to realize that these are a spectrum of a general movement from conversations with patients to more detailed conversations about things that we have to do in caring for them. So the next slide is just a declaration of my interest. So I founded a small company called Run Safely, and we'll talk about that briefly at the end. I'm a clinical advisor for BT Enterprise. They have a health advisory board, and I try and advise them to do things sensibly with regards to healthcare. I'm practicing as an informatician in Queens. I'm an academic. I work generally in general medicine and a little bit of nephrology now. I also chair Northern Ireland's Information Governance and Advisory Council for our EPR implementation of EPIC, which is a large technology program. Next slide. So I think the first thing to think about, and really is the core to all of this, is this right of self-determination that we all have. And the central point is that if you have capacity, and if I have capacity and I have this inviolable right to decide what is done to me in my body. And that's I think, a Donaldson quote. We all have, as clinicians, are obliged by law, and that's just been explained to a degree, and regulatory guidance to behave in a particular way. And that particular way is for the benefit of our patients with the appropriate understanding of what's happening in the circumstance. But it's important to realise, and as we've just discussed, that there is a power imbalance between that relationship between clinicians and patients, in the sense we have a lot of information, patients often have some information, and part of the job is to try and change that understanding and to make it a more straightforward decision. But it's not a straightforward decision, and we all know that. And I think that over the last 15 to 20 years, the case law, which we've just discussed, has shown a movement from, I think, a degree of paternalism towards a patient-centric and a decision-making approach, which is centered around what patients need and what they want. And that's only the right way to proceed. Next slide, please. But consent, I think we would all recognize, is sort of everywhere. And realistically, it's usually implied in the way that we behave. So every time somebody comes into a consulting room in a primary care setting or any hospital, right, patients to be examined, they're consenting to be there. They're consenting to have that examination or that conversation with you. They're having blood tests, and sometimes those blood tests are for significant things, or for genetic testing, for infectious diseases, and there's a consent process even in those aspects of what we do. For imaging, we often ask people to have CT scans or other types of imaging, and there are sometimes unexpected consequences of those images, so-called Watsits that we find in scans that we weren't expecting, normal variants, but sometimes not. And patients sometimes don't understand that when they move into this sort of train that is the NHS, they sometimes intervene and have subsequent outcomes that they weren't expecting. And that's difficult for us to describe to them because we're, at the first instance, trying to provide them with the right care. And even history taking itself has changed with regards to that. We are already starting to record information and then put it in a place that becomes, whether it's a digital or paper environment, something that can be re-exposed or looked at later on. So the consent process for even examining people and taking their history is important. And I sort of think about this most of the time in practicality when I think about prescribing. And I've just mentioned about DOACs, the replacements of warfarin directly absorbed anticoagulants. It used to be that I would do that if somebody went into AF or had a PE, but now actually there's a pharmacist with a protocol, and it reflects the fact that for some higher risk interventions, the consent required becomes more explicit. And I think that has been by tradition, unclear how that was going to happen. But as we move towards a medicine where there's much greater interventions and sometimes greater risks, therefore the description of consent, but also the recording of that consent has to be more explicit. For instance, DOACs and older people who are at risk of falling, that takes up a morning sometimes trying to explain the risks before and against the use of these medicines. And it is a difficult spot. Next slide, please. But there are some pretty fundamental and core basics that I think we can all accept. You must be trained and have requisite knowledge. If you're going to recommend the risk of a test or a treatment or an intervention, you have to understand what that is. And if it's a procedural based thing, then you should be able to do it, or at least you should have done it in the past and you should have an understanding. And you can't really delegate it to somebody who doesn't know how to do it. Certainly houseman, as I was 20 years ago, that was commonplace, and I don't think it is now, thankfully. And it's certainly something that has become, much less common over time, and that's a great thing. But also your practice must be in line with what is standard practice. Not quite like Bolam in the past, but not dissimilar in a way. If you're going to consent somebody for a standard procedure, it should be that standard procedure based on the premise of what you've agreed to do. If you're doing something that's more risky or it has an additionality, it requires a more explicit level of consent and an ability to record it in a way that I think demonstrates that you've gone to great lengths to explain why you're doing it in a different way, because you'll be judged on that decision if something should happen that was unexpected or untoward. Next slide, please. Fundamentally, I think that this conversation comes down to the patient-doctor or patient-clinician relationship. And, it's the key to trying to help us get through this journey. I appreciate it's sometimes difficult when we don't have the time to bond those relationships that we previously had. But you have to try and explain, in a sense, in the story that you're creating in a set of notes, whether that be on an EPR, it sounds ridiculous in a way, but a paper set of notes or in the conversation, the documentation of that relationship is key. And for me, I think the critical aspects of that, when you look at the literature, are the fact that you were able to indicate that you spent time and that there was an intent to explain, and we'll come on to that in a little bit of time to explain what I mean by that, and that there's transparency. If there's an explanation that is key and upfront that explains exactly what it is you're planning to do with the risks, and the documentation of that is there, then I think you're in solid ground to progress. But also it makes people, i.e. patients, more comfortable in that relationship. And there's certainly good evidence that patients prefer people who they know to do procedures. Now, sometimes that's complicated because they're not the people who will do the procedures, but people are very comfortable in that relationship. And that's why I still think within primary care, the relationship is closer and sort of leads to a likelihood of a smoother movement through difficult decisions and consent making. The next slide, please. So I suppose it's important to reflect on some of the reasons why some of this matters so much. And it's got two rules. I think it matters to us as clinicians because it affects us in the way that we practice, but it matters to the NHS as a whole. So just over half of all NHS complaints are in some way related to alleged poor care, some form of negligence or communication errors. And about half of those are related to doctors, mostly. And everybody's suffering in this. This is an unhappy looking doctor on the right-hand side. But if you've been involved in a complaint, and I certainly know I have, it is stressful. It is difficult to concentrate on other things. You're focused on it, you question why. You spend a lot of time trying to figure out, did you do something wrong, or was it a consequence of what happened? But it's distracting. So therefore, we as clinicians want to provide the best care we can, but something comes along that happens, and then suddenly we can't do that because we're preoccupied by something else. So these are significant events for a lot of us. And if they proceed to legal involvement or contacting the MDU or colleagues, or further still leading to some form of legal dispute, that can become very stressful and can take over people's lives. And from a NHS perspective, it's incredibly expensive. NHS resolution currently pay about £4 billion per year. About 40% of that's admin, actually. So the lawyers on both sides and the conversations around how the case is dealt with or settled. And if you think about this going forward, because they don't save the money for this, they pay it out of general taxation. So there's a projected bill of about 140 billion that is currently planned to be paid over the next period of time to deal with the medical negligence issues that exist now already. So it's a significant problem. The next slide. So this is a bit of a personal reflection on my first experience of something a bit like that, and dealing with transparency and risk. And just at the outset, the patient was fine, and he was happy enough to allow me to consent to write this paper up as one of my first publications in life. For the radiologists out there, this will be truly straightforward, and for the cardiologists, but on the bottom film, there shouldn't be that sort of round circular fluid around the heart there. That's a pericardial tamponade. And as a registrar, I changed a temporary catheter to a large bore catheter in renal medicine to allow dialysis. And an unintended consequence was this gentleman ended up with pericardial tamponade. And he recovered very well. He continued to go on and have his dialysis, and we got on very well, and I spent a lot of time looking and caring. I spent a lot of time caring for him. But the point that this made to me as a registrar and as a junior doctor training is the materiality question. Some things are so important that they should always be explained. And I had, up until that period of time, been in central lines quite a lot and hadn't consented people for the risk of something very serious happened to them because it hadn't been something that I had considered. But for the rest of the 10, 15 years since I've been practicing, it's something that I always consent people for. And the materiality issue is one that has already been mentioned, but there are certain things that we should always mention because they are such risk that even if they happen infrequently, people would want to know them. And then there are other things which we'll come on to later, which are specific to that patient that might be very, of little risk to other people, or they wouldn't even want to know about it. But for certain circumstances, people would want to know about it. And they can be quite strange things, like positions of pacemakers because they do certain things with, violins, or it might be that they use their hands, and if they're having angiograms, they would like a different type of route to be used. But these go back to the relationship that you have with patients, and it can be quite difficult to find those relationships to allow you to make those decisions. But it is something that materiality sort of demands of us now, that we do have a detailed understanding of why patients might want things done in a different way based on their own circumstances. Next slide, please. So how do we do as the GMC asked us? So we're supposed to give patients the correct information they need about their future condition, their treatment, and what might happen in the future overall. The bit that I find quite difficult is they need to understand it, and we need to be satisfied amongst ourselves that the patient understands it and agrees to it. That's a concept I find quite hard to understand myself sometimes. How do you know if somebody understands what we've explained to them and understand it to the point that they can proceed with the procedure or the treatment plan that we've come up with? And not only that, we have to record it all in a way that somebody can understand in the future should they need to. Next slide. And there's more. We have to, at the same time, respect. So we have to give them an opportunity to go through that decision point and to have a decision to have. Yeah, I'm hoping you have, and somebody can't, please let me know. We have to respect their right to decline that treatment or to be involved in any of it, the research or the teaching. They have the right to say no. That right is part of their capacity and their ability to be involved or not as they choose. And at the same time, we have to explain the nature, the purpose, the risks, the side effects, the benefits, the alternatives, all of the things that were originally discussed in the first part of the talk by Jerard. There's a lot of things that we have to get across. On the next slide. And we have to do that at the same time as surviving the clinic. So this is not a straightforward or easy task, and I don't think that anybody who does this for any period of time would expect it to be so. And one of the practicalities is how do we try and make this happen in a streamlined way, in a straightforward way to allow us to get on with our day, to provide the care we want, and to come up with methodologies that allow us to get what we need to get across to patients and allow us to proceed. And we'll go through and discuss some of these as we look at the literature that allows us to see what's been used in the past and what sometimes is now looked upon as a future way of doing this. So next slide. So one of the things you need to think about is there's a decision about how much information is needed and how is that explained to people and what decides that amount of information that must be left and made available to patients. It definitely affects the complexity of the procedure, the side effect profile of the procedure, the urgency, the materiality, as we've just described, based on their lifestyle, potentially their career, the risk benefit of the procedure and your bias in that, i.e. whether you're somebody who's got a particular interest in the procedure involved, whether you've designed it or been involved in it, you have to consider that possibility. And for the above issues, they often lead to the problem, the last point, which is responding to questions and allowing time to reflect. You have to give people a chance to absorb the information, to go home, to think about it, to reflect upon it sometimes, discuss it with family members before they make a decision about it. And certainly when I was a younger doctor, consent was often done right before the procedure or done at a time period on a temporal line that was not changeable by the patient at that stage because they were in a position where they were sort of on their way to something. Thankfully, that's changed, and I think that's something that's going to continue to change as we start thinking about whether the consent procedure should be separate from when the actual procedure has been planned, and that's a common thing for elective procedures. Obviously, with regards to urgent procedures, that's an entirely different space, but I think most trusts now have a plan by which they can set up this environment so that there's space and time to have the conversation, to reflect, to ask questions, and to come back and reflect on what we're going to do next. It is a conversation that needs to evolve, and I think that we need to get used to the idea that that's just the way this is going to be, as difficult as that might be. And the second last point about it's conditional consent sometimes, it's getting harder and harder sometimes because we're dealing with a population that are older, that multiple comorbidities, and who often have issues with their own ability to make decisions about other things. So it's perfectly feasible to be suffering from dementia, have a hip fracture, and having to be consented for whether or not you think this hip fracture needs repaired or something more minor that needs to be done. And they're not mutually exclusive. The decision about what's being done is related to that decision itself. It's not necessarily related to other things. So it has to be contextualized for the procedure that you're considering or the treatment or the plan that you have. And again, that's something that I think gets a little bit complicated and also confusing at times. Next slide, please. So reflecting on some of the evidence in this space, there isn't that much. And I haven't included too many papers, but I thought this was worth thinking about. This is a meta-analysis or a systematic review, actually, looking at improved methods to look at patient comprehension in line for medical and surgical procedures. I'm trying to figure out what methodologies might work best. And it looked through all the published literature, the trials that had been done, to try and figure out what methodologies have shown a difference. So the examples that they grouped them into are these written interventions, including written materials, leaflets, handouts, patient information, standard informed consent, as well as simplified documents. There was a vogue for audiovisual interventions like posters, digital images, send people home with videos, go to YouTube, watch what this procedure is and how it might proceed. Some people use interactive digital interventions in clinic, tablets, devices where people flick through the procedure and look and maybe have an opportunity to look at the procedure itself if they really want to, and they have interactive videos that maybe cartoon-like or maybe scaled drawings. And then the fourth one is these sort of ideas of a verbal discussion where you have you essentially or talk through what the procedure might look like, and then you teach that intervention back to the person who's prescribing. So therefore you're asked to explain what you think I'm going to do to the person who's going to do it. And it sort of looked at these approaches and decided to take a more scientific approach and say, well, which one of these seem to have the best evidence for it? And if you flick on to the next slide, the one that comes out slightly better than any other is this teach-back methodology, where there's a verbal discussion with test and feedback, or as they call it, teach-back interventions, that allow patients to explain to the person carrying out the procedure, planning the procedure, what they think is going to happen. That seems to leave patients with a better understanding of the plan ahead and a better motivation to explain it. So there are companies now trying to figure out ways, and health services trying to figure out ways to allow people to sort of gamify this process, to allow people to be involved and interactive in it. Now, the problem again is from an NHS environment, do we have the time, the space, the associated surroundings to allow that to happen so that people really get a really excellent opportunity to proceed in this method? I think that's a challenge, but it's always going to be something that we definitely have to think about. Next slide, please. So the market, and I mean this, the technology market or the healthcare market has responded to this. And there are some companies out there now that are building products that work in this sort of an environment. So Bloomsbury has a system called Consented Patient. Some of you may use it as the surgical consultants on the call or staff. Concentric Health. These are form-based approach which bring people through a process and they can do it at home. And there are many other companies, there are just two I picked, that do this. And that seems to offer an alternative way that you can move some of that risk across, because patients have to do it themselves and to be shown to do it. But it is a complicated space, this, and I think it's going to get a little bit more complicated as we move forward. Next slide, please. So as we will all know, the environment has also changed. This is a nice paper which I read, and then I emailed the author up afterwards, who's now a surgeon doing a PhD in Wales, which is mind if I record this. So I have noticed this over the last 10 odd years, but more so over the last 4 to 5, where people record quite a lot of the conversations we have about major issues, and sometimes not major issues. And sometimes it's not just recordings, but it can be video recordings. The phone's in a different place, or you see the red light on. And the first time that happened to me was, incredibly uncomfortable. And it's good to realize that I'm not alone. That's a normal reflection on this, although I've adapted to it, and as you'll see later, I've come to embrace it at this stage. So how would you feel if a patient asked you to make a recording of your consultation? And it's pretty clear that most people feel quite uncomfortable. The senior doctors or the consultants are the least uncomfortable with it, I think, more or less because they're sort of accepting of it to a degree. Whereas I think junior trainees and registrars, this was an exclusively hospital group rather than primary care. They found it a great deal of a challenge. And the real reason is that nobody really knows where they stand with this. It's quite complicated to figure out, well, what does this mean? And the next few slides, I'll try and take you through that process. Next slide, please. So there's a poor understanding among staff of where we definitely stand with this. So are you aware of any official guidance regarding the making of audiovisual recordings by patients? And the answer was no, by the vast majority of people involved, including all groups sort of similarly. And would you agree to this if the patient insisted upon it? And almost everybody said yes to that. Well, not almost everybody, a large percentage. And as we come along, that's the way it has to be based on what's happened over the last 10 years or more. So let's flick on to the next slide. So the basis of this change, before we get on to the specifics of recording, is about shared decision making and giving patients more control. Within the US, over the last 15 or 20 years, there's been the increase of the use of electronic medical records, which are starting to make the same progress across the UK, although in a slightly different and more ad hoc way. And there's been these two processes, one called open notes and another called open recordings, where people have started sharing much more of the medical record with their patients. The general view in that is that this has been significantly a success. Our gut feeling sometimes, I think, as clinicians is, oh my goodness, there'll be much more to rattle through. People will read this, they'll find things to blame us for, or it's a reactionary thing where we feel frightened by this. But actually, the response has generally been patients are much less anxious. They reduce clinical interactions. They don't actually contact you more, they contact you less. Patients feel more satisfied, they feel more transparent, and there's been a reduction in complaints. And in some of the surveys in the US, about 30% of clinicians in their surveys had started to record these consultations in a way to allow them to happen, or expected patients to. So that's it's a sort of counterintuitive approach, and that sort of reflects the fact that there is different technology in that part of the world, but it also changes the power imbalance that's happened between patients and clinicians, and that it's moved to the patient who's in charge of their care. And in the US, because they're paying for it in a different way, they feel very much in charge of their care. Next slide, please. So the guidance in the UK is reasonably straightforward. Patients are allowed to audio record clinical consultations. It is legal, and they don't really need your consent for that. And that's because this is more or less encouraged by the GMC, by the BMA, by the Cumberledge, which is First Do No Harm report, which basically suggested that in many regards, these recordings are used to help patients understand the conditions that they have, come to terms with them, and help recall. Because we all know that about 80% of what patients are told in a clinic is often forgotten. That number varies between about 40 to 80, but the most commonly used studies about 60%. And by the time they get home, they forget. And therefore, they need some record of what's happened. So I think that for a large majority of when you see them recording, that's what it's about. It's trying to find out what's happening. The anxiety of what's going on in clinic means it's difficult to remember. And then they need that information later on to maybe relay to family members or to figure out themselves what's going to happen next with their care. So they often use this as an aid memoir. And in the US, they have these things called after visit summaries, and this is happening in quite a lot of the part of the world, where people get a quick summary of what's happening to them. We tend not to do that in the NHS because our admin is not quite as advanced, and maybe that'll change as we become more digitized, but there's definitely a gap, and people are filling that gap. So you can certainly ask people not to record, and a large number of patients will say fine, and they won't do that. But you can't refuse to provide them with care if they want to continue to record. So you have to allow them to record in a way if they wish to do so. I've put in this comment about failure to inform claims because I think that it's worth mentioning here about in this mix of recording. Failure to inform claims have really, I think they've gone up fourfold. The members in the MDU might want to correct me exactly what the number is. But a failure to inform claim is where there's a claim initially around negligence or some other side of a poor outcome, and sometimes it fails, there's no evidence of that, but then there's a secondary claim on failure to inform where the patient may claim that they were not informed about what subsequently happened. This sort of, he said, she said, because there's no record specifically of that. And often that is used as an additional measure. So even though you think that sometimes these recordings are bad for clinicians, they're actually more likely to protect you because all in likelihood you will have done the correct thing, and that will be recorded in real time on the digitization. And therefore, actually, I suspect that these recordings are likely to be helpful in the longer term. Next slide, please. So clearly, this is something that I'm interested in. This is the company that I have started. It's called Round Safely. And because patients record their consultations on their own phones, clinicians don't get a copy of that. I didn't think that was particularly sensible in the sense because we want to be able to keep these consultations and have a record of ourselves. So we try and make software that allows you to record the consultation, and then you can share it with the patient if you want, or if they don't want it, they don't need it. you get a verbatim recording of the consultation, it's transcribed, and you can add it to your electronic medical record or print it out, or just keep it in case you ever want it again in the future. And we're trying to use this both for patient communication, but also trying to help people with reducing the risk of medical legal issues in the longer term. We expect this to be used by healthcare environments rather than by individual clinicians to try and leave it there as a protection in the future, to try and help people come up with a safe way to protect themselves when they're providing care and they're feeling a little bit anxious about the circumstance. Next slide. So this is the last slide. And I think the reason that I think it's important to think about this is, so I spend a lot of my time crossing over between technology and healthcare. And the last year has been remarkable. And you will have all heard of this thing called ChatGPT, and some of you may well use it every day. I use it every day. In this space of generative AI, all of these terms in the left-hand column are all large language models or something similar to that. And what these technologies do is they allow you to very rapidly change usually a method of communication or a method of making information available to patients. Already now within the US, a large number of these models are being used to improve the methodology of consent for patients. So essentially, either the information that they're provided to is linked to a codex of information on the internet, so patients can go and find more information that is relevant, or your notes or your clinical environment is being set up to allow you to use that information to provide patients with better understanding of the procedure they're about to have and follow up for it. And I think that it's important to realize that this isn't going to change. I think it's just going to rapidly increase. In fact, every single photograph or picture that's been used in this talk by me tonight was produced by Stability AI. So none of these people are real, they're all computer generated. And that ability of technology to advance relatively rapidly now, I think is something that we have to be aware of in healthcare. It's not as if we've got enough CPD to do, and hopefully we've got an hour tonight, but this is the sort of thing that I think we need to become more aware of as we go forward, because there's little doubt that there'll be some crossover between how these models are used with regards to helping clinicians provide better care, but also trying to prevent us doing things that would lead to greater risk in a medical legal sense in the future. So it's important, I think, just to be generally aware of them. Just to finish there and to say thanks for listening, I think that while some of the things we've discussed sometimes are anxiety inducing, I think it's core to go back to the idea of reflecting on the relationship with the patient, being transparent as possible, explaining the risks as you see them in a straightforward and honest way, and trying to make a documentation of that in the short term. And that can be difficult. And in a pressed and busy NHS environment, I appreciate it can be really difficult, but you can only do your best. Thanks for your time.
Mick, thank you very much for taking the time to speak to us this evening. That was really interesting. And you did make me laugh when you said that that all those characters were AI generated. That just shows you, I guess, the power in a very sort of anodyne way, but really interesting nonetheless. John, you've been battling in the background, taking questions, I imagine.
I have indeed.
Have you got a lot that we need to?
We've got quite a lot of questions, so thank you everybody, and quite a lot of activity at the end, I think, to do with recording, which we'll come on to. But the first question I've got, and perhaps Jerard, you might like to answer this, is about national consent forms. Now, my understanding is this might be sort of a pre-populated template consent form. Do they reduce complaints or claims?
I don't think we've got the evidence to comment on that in detail. Maybe Mick will come in and say that we do, but I'm not aware that we do. One of the difficulties in claims, and John, you're the claims handler, you'll know a lot more about this than I will, is that there tends to be quite a long tail and things come in quite late. And we're probably only just starting to see changes in the claims environment as a result of Montgomery. There was a paper from Queen's University in London about a year ago, maybe 18 months ago, that demonstrated that we're starting to see claims go up. And they're tagging on issues of delay, of failure to inform, and that's fairly robust research. So I'm not sure that there is information about that out there to say that definitively we're reducing claims. What I would say, the downsides I can see of it is that's a one-size-fits-all response. It's saying these are things that you must say, but of course it doesn't address the issue of materiality, of what the patient wants and what the patient needs to know, what is particularly important to them. However, it does provide some other information that a group of experts in the field think should be important to many people. So it takes some of the information. It's helpful in some ways, but I don't think it's going to be something that's going to turn around the rising claims that we see, not all of which are due to consent, of course. There's lots of other things out there that result in those claims going up. Mick, do you have any comments?
So I haven't seen anything to suggest that standardizing forms will make a significant difference to that, but that, as you've commented, that will take some time to see. I think the next thing that's starting to happen is the use of technology within EPRs, not necessarily on this side of the water, but on the other side of the water, to intervene as you progress to suggest whether there are gaps in a piece of information that's been given or consented to. So there's lots of work being done now to try and identify, can you see in real time that a consent is incomplete or that there's a piece of information missing? So I think that might supersede what we currently do. But again, you require a baseline technology to do that, which is often not present in the UK just yet.
And of course, the other thing is, John, is the idea that a consent form is evidence that a form has been filled out. It's evidence that some discussion may have taken place, resulting in that form being filled out, but it's not evidence that the informed consent process has occurred. So I guess it would also depend on how that form was used. And as you know, John, technically speaking, signed consent forms are required for a vanishingly small number of things in reality, in law. Of course, it's best practice. We'd use consent forms all the time, but in terms of what you actually need to sign a consent form in law, it's actually quite a small number of very specific procedures.
Yes, and from my experience in dealing with claims, it can be often a helpful starting point when we're investigating a claim to have a consent form which has the usual risks that are documented and might have been pre-populated, but also, as we've said in this talk, consent is a process, and it isn't just that final form. It is the discussions that you're having with patients during the clinic. It might be which you might comment on in your clinic letters, for example, or in your clinic notes. It might be also the information, the written information you give, or the signposting you give to patients is all relevant to that consent process as well.
Thanks very much. John, was there anything else? I mean, I'm not sure we're going to ever answer these questions perfectly for everybody. These things are also fact and situation dependent. John, what else have you got?
Well, I think there's a very interesting question from perhaps somebody who's a trainee who's worried about consenting a patient for a procedure that they're not actually going to be doing. And I think that's a query that we've had on the advice line before. So perhaps we could answer that one.
Mick, you kind of touched on
that. Yeah, I think if somebody has good understanding, of a procedure, they've seen it, they understand the consequences of it, and then they're probably in a position where they can provide a decent level of consent for that procedure. Now, I think to be, absolutely rubber stamping it, I think, it would be best if you could do it and you knew what you were doing and you were doing it. I don't know that there's a defined answer in law, Jerard or John, that answers this, or if it's been challenged. But I think that
I think you're right. I think you're touching the right thing. I mean, when you say law, I think that's a slightly different thing. We're talking about whether there's settled case law on that particular.
Yes, exactly.
And I'm not sure there is. I'm sure there isn't statute specifically on that. But what I think there is out there, which has the effect of law in some ways for us as doctors, is the GMC guidance, and it talks about if you're going to delegate it to somebody, you should be delegated to somebody who's got understanding of the risks and benefits of the procedure, will follow the GMC guidance on consent, and that's this basic process. So I think that your idea that somebody has to be able to do something, as an interventionalist myself, as a surgeon myself, I think that makes sense, because certainly for anything other than the most basic things, you want somebody who's got the experience of it and has understood how things can go wrong. I think that what you described of chasing, I remember as a junior chasing people along corridors to get consent forms signed, but I didn't really know the details of the procedure at all. It was just terrible. And we've moved away from that completely now, and thankfully we have moved away from that. So I think trainees can consent patients as long as they understand the procedure, they're able to explain the procedure, follow the GMC guidance, and have appropriate support, and have been signed off by their consultant as competent to do that. It's not something you should do. And I think the new GMC guidance, which John and I have seen, is coming out, Good Medical Practice. It talks about trainees being able to ask for support and help, and it not just being expected that you'll go and do the consents before surgery or before the interventions, that you will be supported by your consultants to do it. And ultimately, of course, the consultants remain responsible. The GPs remain responsible for stuff that they do when a GPST is involved in it. So the senior person who delegates it is responsible for the outcome.
Okay, thank you. And we must get on to the questions about recording consultations, because that's generated some activity. So, so perhaps Mick, when you're talking about recordings, are we talking about just audio? What about video recordings?
So audio or video, but primarily I think what most people record are audio. If I have been recorded on video a couple of times in A&E, it's just happening, and I don't know what you can say about that. And so I've given up worrying about that now. I now just hope that it reflects that I am under the Hawthorne effect and I become an even better doctor, I hope. And that's just reflected. And I think that's the way to view it. I don't think there's any other significant way you can deal with it now. So hence my response to it, which is just to try and build some software that allows us to control it a bit more, and still yet provide patients with what they want. It is awkward, and I've done this many times with other colleagues, and they find it awkward. But I suppose my response to that is, there's somebody in front of you watching, and that's the patient or the family. They will have a memory of this, and their memory of this will be better than yours, I suspect. And that's what will probably be taken if anybody ever asks a question about it. So that's my view.
And I think also, think about all of us, wherever we go now, we have got usually a smartphone on us. Or, when you go into a ward of patients, every other patient has a tablet or a device that can record. So it's probably good practice to just think everybody is going to be recording you.
There is another side to that, though, isn't there? The idea that patients might come in and start recording in a public area. They might start recording other people's personal journey or difficult moments. So I think there have to be some sort of organizational approaches to this. So it's not for an individual doctor to get into a fight with a patient. I don't mean a literal fight, a dispute with the patient about it. The trust, the practice, the hospital should have a process of how they approach this. They should have things up saying you're not allowed to record in public areas. You can record your own consultation. I think that it becomes difficult for doctors when your face is being filmed by camera a little bit away. There's an issue of privacy. There's your Article 8 rights under the Human Rights Act. There are some issues there of privacy, particularly if somebody uses that thereafter to harass somebody. The Protection from Harassment Act comes in, or if it's being used to defame somebody. I think the problem that we've got with this question is, of course, that again, the case law isn't out there. We haven't pursued cases specifically. We don't have something to fall back on. The one recording case that we can fall back on is one called, I could get this wrong, Flowers v. Mustard, I think, wasn't it, from 2019, I'm going to say. I may have got that wrong, but basically an expert was recorded without their knowledge. No, they did know, and then they asked the patient to switch it off. The patient fumbled with the phone, tried to switch it off and failed to switch it off. It was then used and it called into question the expert's assessment, and the court decided that it was allowed to be used in evidence. And actually, it didn't turn out to be actually harmful, but it was used. So recordings are a fact of life, unfortunately. We can't necessarily stop them. We can try and control them. We can step in when they're being unreasonable and when they're harassing, and that's what defence organisations can do for doctors sometimes. And Google and those organisations, if people post these things, will sometimes step in, but not as often as we might like. In truth, I think that's my experience of it.
Yeah, I think if anybody, if it's for the private consumption of the patient to inform themselves, it's very difficult to see any other alternative. I think if they choose to affect your privacy or your ability to have a private life, then you have some legal recourse. But that would be, I suspect, I don't know, probably not as easy as you expect. Although some of the social media companies are getting much better, some of them are still pretty unreactive.
Often the social media companies, there are terms and conditions. If you're one of these sad people who actually reads the terms and conditions, then they often will act, they will say that disclosures made in the public interest, like to do with medical care, are treated differently from disclosures made about a private individual. So often it's actually a steeper hill to climb to win that. I'm mixing metaphors all over the place. To win that battle, it's not straightforward. John, anything else on recording?
Well, I think on just that point, I think there is something quite important for doctors to be aware of, that if things do enter the public sphere, the internet, and they've been recorded, is they should always seek advice, and they can contact the MDU advice line, but be careful about patient confidentiality. A patient may discuss all the intricate details of their consultation with you, but if you try to respond, you may be disclosing confidential information about them. So it's just worth bearing in mind.
No, but it's a very tricky, it's a very difficult area, and I don't doubt that everybody, people feel anxious about it, and I don't know what to say. It's one of those I don't know what to say moments. It's just life at the minute.
And just on that, just on that point, if a patient refuses to give the recording to you, somebody's asked, is there any recourse for that?
I don't think so.
Is the short answer, because they're recording their own personal data. You're not acting in a personal capacity, you're acting in a professional capacity. Therefore, their privacy, their data privacy would trump yours in that circumstance, because you're acting in a public capacity. That's a very rough way of saying, but basically it's their data that they want to hold on to. They're entitled to do so.
Yep.
Have we got time for one more question, do you think?
Time for one more. If you've got something there that we can try and address, I think we can probably manage.
Yeah. Okay, so I think that there's been a couple of questions about patients who don't want to participate in the consent process. So they've said to you, doctor, I don't want to hear about the risks. What do you do with those in that situation?
So from my perspective, I do my best to inform them of the risks anyway, until they desperately tell me not. I provide them with everything I do otherwise, and then eventually I say to them, okay, I accept that there's still my job to provide the best care I can for you, and then I proceed based on what I think is the right thing to do.
I don't think I've got a lot more to add to that. The GMC approach this in their guidance, don't they, John? It's in there about what you're meant to do, and you're meant to explore their reasons to use their language. You're meant to try and give them basic information if they'll accept it. Ultimately, you've got to tell them as well that it may impact on the validity of their consent, which I guess may be true. I'm not aware of any specific case law where a patient's refused information and successfully sued an organisation for failure to provide information. That would be something that's not going to get past the first hurdle, one would imagine. But I think that the important thing for doctors, as ever, as we say in the NDU, is to have some notes written down about it, have some record of the fact that you've attempted, and this was the result of that. So it does happen. It's awkward when it does, but as Michael said, it's important to share what you can, what they're willing to hear, and ultimately do what you feel is the right thing for them with their consent, however limited information provision has been in that circumstance.
Okay.
I think then it's only falls to me just to say, Mick, thank you very much for your presentation. It was actually fascinating. It was a lot of interesting stuff in there that I didn't really pick up on. We have used ChatGPT a little bit in the MDU. I can't say we were blown away by the quality of the information it provided to us on technical legal things, but maybe that was to do with the quality of the question we asked. John, thank you very much for getting the questions together. Thank you in the background, Caroline, for helping us, and thank you all for turning up. I really appreciate it. Remember, please do fill in the feedback. Sorry for any technical difficulties. Let us know of any other topics you want us to do, and have a great night.